elevation or the persistent higher pressure which is the exerted on the blood vessel wall. So what are the dependents on the blood pressure or the hypertension? That is actually the arterial tone, the vascularity, the elasticity of the vessels of the blood vessel wall, and the cardiac functions. This is what is the systolic pressure, what is the contractility of the heart, what is the rate of the heart, what are the other comorbidities which are affecting the muscles of the cardiac or the cardiac remodeling. So, इसको आगे कहाँ से? The hypertension is defined as the blood pressure values of at least two different occasions at two different times. And systolic blood pressure more than 140 and diastolic blood pressure more than 90. Probably this one is the old, and the new guidelines says that the normal blood pressure is less than 120 and 180. And the hypertension is labeled as the stage 1 hypertension when you have the blood pressure more than 140 systolic and more than 90 diastolic. Now, one thing to remember, when your patient come across to you for the first time with one reading, you should not label it as a case of the hypertension. You first have to make it sure that whether you want to label it as a case of hypertension, number one. Second, you want to start with straight away with the medications, or you want to have the lifestyle modifications before taking any further decisions regarding the hypertension. For hypertension to be declared as a case of the known hypertension for the new patients, you have at least two different values at two different occasions. And the main determinant is that the patient should not be exerting at the same time. You just keep the patient relaxed. After taking the rest of 5 to 10 minutes, max 15 minutes, then take the blood pressure. And that reading is labeled as the exact and accurate value of the blood pressure. Obviously, the patient, when comes to you in the clinic, the white coat hypertension and the other determinants and anxiety stress factors, that must be excluded at the time of labeling the patient as a case of the hypertension. So why is it important to know that patient is hypertensive or not? The hypertension is more common than diabetes mellitus. The 90% lifetime risk of developing hypertension in the patient in the above 55 with normal blood pressure. What we see in our clinics, in our private practice, or in our government setup practice, that patient comes to you and they say that we have nothing. We are all having the healthy life, and when they present you, they have the elevated blood pressure of 160 systolic, 170 systolic, and still they are asymptomatic. So those are the patients which needs to be addressed. We should have the counseling, proper counseling of such patient. That screening is very important. One lacuna in our health system is that we do not screen the patients. The patient comes to us, patient says we are okay, and we say okay, he is not able to check his blood pressure, he says okay, so we say so he's okay. No, every patient above 45-50, we should have a screening program to check those patients, whether those patients are in the category of hypertension or not, because the risk is very high in the patients above 45 or 50. Even though their family history is not significant regarding the blood pressure, still they are at the risk of developing the hypertension, and we have to screen it. So effective control reduces the excess morbidity and mortality. We all know that 62% risk of hypertension is associated with cerebrovascular accidents, and approximately 49 to 52% risk is associated with coronary artery disease. So these are those complications which are very sudden, and that is very disturbing for the patient and their family as well. So if we have a good screening program, we can have the early detection of this hypertension, and we can have the effective control of this hypertension. So this point is that systolic blood pressure of 115/75. As I mentioned earlier, that nowadays new guidelines tell us that the normal blood pressure is less than 120 systolic by 80 millimeters of mercury diastolic. So with every increment of 20 millimeters of mercury and 10 millimeters of mercury diastolic, above 115 and 75, it doubles the risk of coronary vascular cerebrovascular diseases. So that's significant actually. 1/3 of the population still unaware of their hypertension. So here comes the screening, which is very important, keeping in view the age. Even the young age hypertension is very common nowadays, probably because of our lifestyle, because of our diets, which we are having nowadays. 40% of individuals with hypertension are not on treatment. Mostly patients, when present to us, they are reluctant to take the treatment. They have many questions and many queries regarding the management. As the common question is, डॉक्टर साहब ये दवाई हमें लग तो नहीं जाएगी, क्या ये दवाई हमें सारी उम्र के लिए खानी पड़ेगी? And still they want to have the lifestyle modification, or still they think, which is the common old concept, that blood pressure readings surrounding 140 or 90 millimeters of mercury diastolic, that they are the normal for them. So we have to counsel the patient and educate the patient. The majority of the patients with such blood pressures, they usually don't take medicines. Even they start taking medicines, they try to skip it just by having the concept that their blood pressure is controlled. We have to educate them that their blood pressure is not controlled. Our target is not achieved. So majority of the patients, they are not on treatment. But the point is, how many patients achieve the target? 2/3 of the patients on treatment have blood pressure less than 140/90. So again, the target is very difficult to achieve in those patients which are reluctant to accept their reality that they have to take the medicines throughout their life with all the lifestyle modifications. We all know that the society which we live, we are very fond of eating the junk foods. We are very fond of having a sedentary lifestyle. We are very fond of having different sleep habits and all that things. The other contributing factor, which is very common, especially on those patients which are still taking medications and having the uncontrolled blood pressure. 1/3 of the patients have high dietary sodium. One research in 1980 was conducted, and that showed that patients living in the coastal area, they have the high salt in water. They are used to take it. They compared the blood pressure of those patients which were living in that area to those patients which were living on the other areas. They had significant blood pressure difference even on those patients which were not hypertensive. And the difference of systolic blood pressure was 10 to 15 millimeters of mercury, and the diastolic difference was 10 millimeters of mercury. So from here, the concept of the sodium restriction and the salt restriction came up. That was in 1980. The dietary sodium should be reduced. And what is the cutoff, we will discuss later in our presentation. Approximately less than 4 grams in per 24 hours. If the patient is having the hypertension, so that doesn't mean that he will only have the hypertension in the next coming years. Even hypertension can lead to the increased risk of diabetes mellitus in next 5 years if it is poorly controlled. Well, if we have a controlled blood pressure, we have the controlled hypertension, we can live a normal life even in the 7th and 8th decade of our life. But if it's not controlled, the risk doubles. In every risk is 2 to 2.5 times every 5 years. Approximately 1.13 billion people worldwide are affected with hypertension. It's a huge number out of 6 billion population. Hypertension is a major risk factor. As I mentioned, that approximately 62% of patients with uncontrolled blood pressure with hypertension, they present with cerebrovascular accidents, and 49 to 52% with coronary artery disease. And we all know that both conditions are life-threatening, and even if they are not life-threatening, they can cripple the patient. Most people with hypertension, they have it. This is the point where screening is very important. So uh, the global hypertension burden is huge and it is increasing. So what are the hypertension stages? So this is the old classification. The optimal blood pressure is less than systolic 120 and less than 80 diastolic. The normal blood pressure, which is written over here 120 by 129, is a little old classification. Nowadays 120 to 129 systolic is considered as the elevated blood pressure, and the systolic 80 by 89 millimeters of mercury is the elevated blood pressure. So if we have the blood pressure of 130 more than systolic and more than 90 systolic, we consider it as the hypertension. The normal and the high normal classification written over there, and which is shown on the slide, is the old one. In a new classification, we have the normal blood pressure, which is less than 120 systolic and less than 80 diastolic, and we have the elevated blood pressure 120 to 129 systolic. And if we have the blood pressure of more than 130 to 139 millimeters mercury, we label it as the stage 1 hypertension. So it's a little difference over here. In new classification that was in 2017, 130 blood pressure is considered as stage 1. And if we have the systolic blood pressure more than 140 and diastolic blood pressure of more than 90, we have this stage 2 hypertension. What is the stage 3 hypertension or accelerated hypertension? If we have the patient which presents to us with hypertension or hypertensive urgency or hypertensive crisis, we label it as the accelerated hypertension or hypertensive urgency or crisis. So in new classification, we have stage 1, stage 2, and accelerated hypertension or hypertensive urgencies or hypertensive crisis. What is isolated systolic hypertension? If we have only the readings of blood pressure systolic more than 140 in the region of or in the range of systolic, this is isolated systolic hypertension, keeping in view the diastolic blood pressure remains on the lower side. So again, this is the same. So what is the cardiovascular risk? As I mentioned earlier, that the every increase in 20 millimeters of mercury systolic and 10 millimeters of mercury diastolic increases to double the risk of coronary vascular disease or cerebrovascular diseases, especially among those patients with age 40 to 70 years across the entire life. But this risk remains the same in the new or in the adult patients as well. It's an old concept that the patient aged more than 40 have the double risk. Even if you are a young adult and you have the blood pressure reading the same range, you have the same risk. And what is the target range which you want to have? That is around less than 120 or less than 80, that is 115 and 75. A very little and brief overview of progression of hypertension to left ventricular hypertrophy. As I mentioned in the start of my presentation, that all these factors leads to the accelerated hypertension or in resistant hypertension. In this chart, we have a simple hypertension which can lead to two complications, which are directly affected on the or myocardial infarction. Or even if you have the left ventricular hypertrophy and you have the other comorbidities with controlled hypertension or without controlled hypertension like obesity, diabetes, smoking, or dyslipidemias, you have the increased risk of myocardial infarction. So these two things are very important. If you have the left ventricular hypertrophy, you have a diastolic dysfunction. And if you have myocardial infarction as a complication of hypertension, you have a systolic dysfunction. So these two things are very important in the management of the hypertension. So if you have the diastolic dysfunction, that can lead to the hypertensive heart failure or the diastolic heart failure, which we commonly observe in our emergencies, like the patient presents you with high blood pressure and with pulmonary edema and with shortness of breath. So that's basically the diastolic dysfunction. And those patients will presented to you with systolic dysfunctions. They usually have the blood pressure in the normal range or in the lower range, with all those features of the heart failure. So that is basically the left ventricular dysfunction. The heart is unable to pump the blood. Your ejection fraction is lower down. Your pumping ability is lower down. Your contractility is lower down. And all these factors in the long run, if the things are not managed at time, they can lead to congestive heart failure. And we know that the progression from hypertension to congestive heart failure takes the years, the decades. But once you have developed the congestive heart failure, the time to death is only months. So the early detection, early treatment, early prevention of the complications. So once you have diagnosed a patient with hypertension, straight away you evaluate the risk. Straight away you evaluate the risk. For example, the age of the patient. Number two, history of the patient, like the family history. What are the complications in the family related to the hypertension associated complications? Obesity, microalbuminuria, inactive lifestyle, smoking, and the bad cholesterol. So with the age, as I mentioned in my previous slide, with the age above 40, you have 2.5 times increased risk of family history. Obviously, it's a non-modifiable risk factor, and we all patients which has hypertension, we should start screening the patients at the early age of the life. If the patient presents to us with single reading of elevated blood pressure, which are not in the categorization, and we should have the annual screening of that patient. If the patient is adult with one or two risk factors, which I have mentioned over here, the slide which I shown to you, then we screen the patient with every 3 to 6 months. So we should have the regular screening program. Regarding the obesity, obesity is the independent risk factor for the hypertension. It's an independent risk factor. Same goes with microalbuminuria. If we have the microalbuminuria, we have the nephropathy, all that renin-angiotensin system mechanism going on, and we have the nephropathy further worsening the hypertension. So these all factors add on the increased risk. Smoking, again, the independent risk factor, and the LDL cholesterol. So the lipids and the LDL cholesterol, they are the main associated factors which we usually do not diagnose at the time of hypertension or at the time when we start the treatment. We start the treatment just by labeling the patient as the case of hypertension. Other factors should be considered. Reason being, we have to have a good choice of antihypertensive at the start of the treatment, keeping in view all those risk factors. So once you have diagnosed the patient with the hypertension and you have evaluated the risk factors in the patients of the hypertension, the next thing is you look for the complications at the time of the presentation, so that the side-to-side management of those organ damage should be considered, or the choice of hypertension, antihypertensive medications should be modified according to patient, according to risk factors, according to the target organ damage. So left ventricular hypertrophy or reduced ejection fraction, but we will discuss later on that which medicines should be used in those patients. Angina, stroke, kidney diseases, peripheral arterial disease, retinopathy. So basically we have to look for the macrovascular diseases associated with the hypertension. As we have started our presentation with the definition, this is a lateral force exerted on the blood vessel wall. So with the elevated hypertension, we have the shear stress on the blood vessels. So we have the disruption in the intima, we have main atherosclerosis, we have the narrowing of the intima, we have the thickening of the muscularis wall, and we have the thickened, decreased elastic blood vessels, leading to complications of all those organs. In young patient, or in those patients which, despite of adequate antihypertensive therapies, if the patient are having the good lifestyle modifications, if the patients are having the strict control and compliance of medication, and still they are uncontrolled, so we have to look for the two causes. Number one, whether the patient has secondary hypertension, or there are the superadded factors which we still are unable to diagnose in such patients. Once you have started the patient on antihypertensive drugs, so when to reduce the dose, when to adjust the dose, when to titrate a dose, or when to continue with the same dose, these are basically goal dependent targets. So what is the goal? Again, it's a little older slide. For the hypertension, we should have the blood pressure control in a normal individual should be less than 120 to 180. With single to two risk factors, that should be less than 130 to 80. And with diabetes or renal diseases, which should have the blood pressure control less than 120 to 80 millimeters of mercury. One thing to mention here, that we should not target the diastolic blood pressure less than 70 millimeters of mercury. Reason being, we have the increased cardiac risk or decreased cardiac perfusion through coronaries if we have the diastolic blood pressure less than 70. So when we have achieved the target, we should keep an eye over the diastolic blood pressure. That should not be less than 70 millimeters of mercury, because it's directly associated with the reduced coronary perfusions. So again, if you are managing the hypertension with the target with having the reduced coronary arteries perfusion, that will not serve the purpose. So the targets are very clear. In the young and healthy individual, the target is less than 120 to 80, including with organ damage. And with the risk factors and no target damage, that should be less than 130 and 80 millimeters of mercury, but should not be less than 70 millimeters of mercury diastolic, because of the risk of the decreased coronary perfusions. The follow-up every 1 to 2 months, that is the regular follow-up which should be done in a patient on the regular antihypertensive. Again, this is the huge stigmata in our society. If our patient is controlled, they usually lose their follow-ups. So we have to counsel the patient that if their blood pressure is controlled, they should have the regular follow-ups. Because we see many patients, they have the controlled blood pressures over the period of 1 and 2 years. Then they start losing their diet control. Then they start missing and skipping their doses, or they self-adjust their doses. And even then they are asymptomatic. And when again they present to you with all the complications, you come across such complications of the organ damage, or they are in the range of the accelerated hypertension, despite of the view that they are on medicines, but obviously they are not titrated, they do not have the proper follow-up, so the patient comes to you again with the complication. So patient counseling is very important regarding the adherence of the regular follow-up, medicines, and the dietary approaches. Why do we want to control the hypertension? Obviously, to decrease the morbidity and mortality due to the organ damages like congestive heart disease or chronic hypertension and cerebrovascular diseases like stroke. To improve the quality of the life. If you have the organ damage, obviously you are crippled, you have a poor quality of the life. If you come across the patient with a stroke, even if they have the minor strokes, they are unable to carry on their activities. And if he is the only person earning in their house, their whole family is affected. The whole family's life is affected. So we have to consult such patients, especially that their life and their quality of life is very important. To minimize the side effects of the hypertension, to treat the comorbidities, and to maximize the therapy of other cardiovascular risk factors. This is the significance of controlling the blood pressure. Even if you control the blood pressure of 5 millimeters of mercury of the baseline of the patient from which he is presented to you, you reduce the risk of cardiovascular accident by 14%, heart failure by more than 9%, and myocardial infarction by 7%. So this is the impact of reducing the blood pressure only by 5 millimeter of mercury. You can well imagine then when you have the good control and achieving the targets which are given by Heart Association of American Heart Association and European Society of Cardiology, we can have a very huge impact on the reduction of such morbidities and mortalities from such organ damages. So the impact is huge. So other than all those factors of the hypertension, we come across with the brief overview, treatment overview of the patient. So if the patient presented to you for the first time, do not straight away go for the medications before assessing all the risks, before assessing the lifestyle, before assessing these dietary habits, before assessing the sheer stress level of the patient. Because the first thing is the lifestyle modification. We usually come across the patients which are in adequate pharmacological therapy, but they do not have the lifestyle modification. They still are under controlled, or still the target is not controlled on such patients. So the first thing is the lifestyle modification. And this is even for those patients who are not hypertensive, who have the strong family histories, and still they are not hypertensive. So lifestyle modification is even important for those patients, so that if they are to become the hypertensive in the future, the onset is delayed, and that is definitely delayed. The other thing is pharmacological therapy, both a single therapy, initial drug, or in combination therapy, and with the proper follow-up and the monitoring regular of the patient. This thing is very important, that the impact of lifestyle therapy. And the first important thing is the food and the diet which we take. The basic diet which we want to stress is the DASH diet. As we all of know what is DASH diet, that it is the decrease meat, we increase the legumes, the fish, some sort of fish, not every fish, such kind of things in the diet, DASH diet. So with reduced food with added sodium, we can have the systolic blood pressure around 8 millimeters of mercury, so 10 millimeter of mercury. So just by reducing the sodium to 2 grams per day, we can have the huge effect of the systolic blood pressure, that is around 8 to 10 millimeter of mercury. Again, it's a little older slider. By reducing the weight reduction is very important. We can have 3 to 5 millimeter of mercury control of systolic blood pressure with the weight loss. Obviously, alcohol is not that uncommon in our society. Aerobic exercises and dietary patterns. So basically, you have to follow the DASH diet plan. We all is familiar about it. Sodium is very important. Our lifestyle and our cooking habits are very much associated with the spices and salts and the fried things which we all take in our daily life. So these things should be reduced in our 24-hour diet. So what are the goals? This is JNC8. So if the patient is adult and aged more than 18 years with hypertension, first of all, we want to have the lifestyle modification. We have to look for the comorbidities. We have to look for the organ damage at the time of the diagnosis, and obviously we should not forget the secondary causes of the hypertension in such young patients before labeling it as the primary hypertension. Nowadays, the point is we do not use the term of essential hypertension. We say it as the primary hypertension or the secondary hypertension. The essential hypertension nomenclature is not that commonly used nowadays. So in general population, or with diabetes or without diabetes, because we all know that diabetes is the most common complication or the comorbid associated with diabetes. So if we have the age more than 60 years and age less than 60 years, again I have mentioned it earlier, this slide of the JNC8 and the targets, they are a little older. If we do not have any organ damage, or if we do not have any comorbidities, the blood pressure of age less than or 60 years or more than 60 years, that is more or less than 140 by 90. So if we have the diabetes or the chronic kidney disease or the sequelae of the macrovascular complications of both diabetes and the hypertension, our blood pressure goal is less than 130 to 85 millimeters of mercury for both patients. So what to start? Initiate ACE inhibitors or ARBs or calcium channel blockers alone or in combination with non-black, or in black patients initiate thiazide or CCB alone or in combination. One thing is new over there. In 2020, American Heart Association released the guidelines saying that if the patient is presented to you with the stage 1 or stage 2 hypertension, it's preferable to use the drugs with combination, not with the single drug. Because at the time of presentation of patients with stage 1 and stage 2 hypertension, that is more than 140 millimeters of mercury and 140 by 90 millimeters of mercury, already they are in the stage 1 and stage 2 hypertension. As the new classification says that we have normal blood pressure, elevated blood pressure, stage 1 and stage 2, and the cutoff is lower. Less than 120, 80 is the normal, I repeat, and 130 to 139 is the 120 to 130 is the elevated blood pressure, and more than 130 is stage 1 hypertension, and more than 140 is stage 2 hypertension. So for those patients in stage 2 and stage 1 hypertension, the recent recommendation is that you start with the combination. Why to start with the combination? Probably because when we see the pathophysiology of the hypertension, we all know that it's multifactorial. Not even a single mechanism is responsible for the hypertension which is going on. So the initial single drug combination is usually the insignificant or is under dosage to control all the hypertension. So it's better to start with the combination. From which to start? Two main drugs, ACE, ARBs and CCPs. They are basically the recommended ones. We will discuss later in our presentation. Beta blockers are actually not indicated in those patients which are in need of beta blockers. Like beta blockers are only used on patients with coronary artery diseases, in the patients of stable congestive heart failure. Otherwise, beta blockers as the first line antihypertensive is no more recommended. Most of our patients which are old age, not controlled on medicines, they first time present to us and they are only taking the beta blockers because they say we are taking these medications for decades, and they are reluctant to change their medicines. So we first of all make it very sure that beta blockers are not the first line antihypertensive anymore except in the patients with stable congestive heart failures. So this is the guideline or the flow sheet for the management of the hypertension in the patients from which drug to start. So you can see that in the step 1 we can have a combination of the drugs or initial therapy in those patients in which the blood pressure or the hypertension is not that severe. We can start with the ACE inhibitors and ARBs and calcium channel blockers. The differentiation of the age is no more considered. You can start with calcium channel blockers in those patients which are younger than the age 55. Same case with the age 55 or over, we can add or start the patient with the ACE inhibitors or ARBs. But usually if they present with the stage 2 hypertension or stage 1 hypertension, stage 2 or stage 1 hypertension, we can have a straightaway combination therapy. So we all know with the recent guidelines, the combination therapy which is widely accepted and widely used is the combination of calcium channel blockers with ACE inhibitors or ARBs or thiazide diuretics. But most commonly, the combination of calcium channel blockers with ACE inhibitors or ARBs is commonly and widely used and accepted. So what for the resistant hypertension? For those who are compliant to medicines, who are having the strict dietary approaches for the lifestyle modifications, and still they have not controlled the controlled blood pressure, we can use, in addition to calcium channel blockers or ACE inhibitors, ARBs, and diuretics, we can have a low dose spironolactone. And then comes the role of beta blockers and alpha blockers. Obviously, beta blocker is preferred over the alpha blockers for 2 reasons, in addition to CCB, ACE and ARBs, because in the long-standing hypertension, they are going to lead the coronary artery disease and the left ventricular hypertrophy and the congestive heart failure, and there comes the role of beta blocker. So in those patients, beta blockers are preferable over calcium channel blockers when we have the volume overload conditions, because one side effect which is commonly observed with the calcium channel blockers in the patients with congestive heart failure is the volume retention and the swelling of the feet and the body swelling. So here patient becomes non-compliant to such drugs. So beta blockers are preferable anti-hypertensive or anti-anginal or as a treatment in coronary artery disease or congestive heart failure stable. And when to choose the beta blockers, we usually choose cardioselective beta blockers like bisoprolol or metoprolol and all that. So this is a very basic and basic concept that you have the 4 classes of drug: ACE inhibitors 1, beta blockers 2, calcium channel blockers and diuretics, and one by one you add on therapy. A little older concept, not used nowadays. So the treatment recommendation flow sheet. The first treatment recommendation is obviously the lifestyle. As we know that lifestyle interventions, we are focusing again and again with lifestyle modifications. And if you see the patients and you take the proper history of the patient on those who have not adequately achieved the control, you will come to know that even despite they have the good dose of antihypertensive, they are not strict to their lifestyle. It's very important for in our society, where we take the nashtas of naan chane, prathas and niharis. So patients, they usually say that, Doctor साहब हम दवाई ले रहे हैं तो इसके साथ हम सब कुछ खा सकते हैं. We have to discourage this concept. This should be discouraged. most of the patients who are not controlled, they have poor lifestyle. They are not convinced to dietary approaches which is good for their health. So the presentation all about the role of amlodipine. So few words about the calcium channel blocker, as it is one of the initial therapy and as one of the first drug to be used in the combination therapy. The calcium channel blockers, the mechanism of action is that they affect by dilating the arteries by reducing the calcium efflux by the L-type calcium channels, effectively lowering the end arterial pressure in combination with other drugs or those drugs which are used for treating angina or the cardiac arrhythmias. Because calcium channel blocker including amlodipine, it is widely accepted in all patient groups regardless of the age, sex, race and other factors. It can be used in all age groups safely. So that is why it's the first line both for initial single drug management or in the double drug management. Non-dihydropyramid calcium channel blockers are more negatively chronotropic and inotropic. So this class is only limited for those patients associated with the cardiac dysrhythmias or arrhythmias, or the patients who need beta blockers. Extensive experiments with the randomized controlled trials show that initial calcium channel antagonist prevents the administration of amlodipine. That prevents the cardiovascular mortalities, cardiovascular morbidities, except the heart failure, which I mentioned, that it can worsen the volume overload condition and it retains the volume. So in those patients with heart failure, if it's stable along with beta blocker, diuretics obviously are the superior in the first line other than except the calcium channel blockers. So what are the effects of amlodipine or mechanism of action of hypertension management? Through L-type channels, in reducing the calcium influx and reducing the end arterial pressure. So when there is end arterial pressure is reduced, there is vasodilatation of the vessels, the oxygen supply is increased, and obviously the contractility and oxygen demand is reduced. So with both central and peripheral mechanisms, calcium channel blocker amlodipine is effective in controlling the blood pressure both centrally and peripherally. So a single study to show the first line agent of amlodipine as antihypertensive. So objective of this study was, the hypertension is well established for cardiovascular diseases. The one of the oldest group of the antihypertensives is calcium channel blockers. The amlodipine was compared with other classes like beta blockers, diuretics, and ACE inhibitors as a single drug. And as a single drug, calcium channel blocker was safe and was good enough to control their blood pressure when there is a need of single antihypertensive. So do not confuse the amlodipine that is the only single drug to be used. Obviously, when you are in the need of combination drug, then you are in the need of combination drug. But when you have to use a single drug, the calcium channel blockers are equally effective as the first line agent for single pill therapy or single drug use. One additional benefit with amlodipine is that we have the minimum blood pressure variations while the patients are on treatment of amlodipine. With other drug groups like alpha blockers, with the diuretics and with ACE and ARBs, initially when you start the drug, you have the huge variations in the blood pressure. One thing which I like to share, which the patient complains to you, that when the patient presents to you with the higher blood pressures, you straight away give the anti-hypertensive and we control the blood pressure. The patient presents to you, Doctor Sahab, हमारा blood pressure तो लो रहना शुरू हो गया, हमें तो बहुत weakness रहनी शुरू हो गई. So this is because the blood pressure variability in 24 hours is huge with other medicines like ACE inhibitors and ARBs, or when you start with the combination therapy. This effect is very minimum when you start with single drug, and when you want with a single drug, you start with amlodipine, you will be having a very low 24-hour variability with the blood pressure. So patient will have a very minimum complaints of the hypertensions or the effects of hypertension which they feel while initiating on the antihypertensives. Again, another study showing them amlodipine is effective as a single drug. So this is the last slide which I want to share with you people. Just compare the difference between the variations and the control of systolic blood pressure index with amlodipine monotherapy and with amlodipine with single antihypertensive drugs, 2 antihypertensive drugs, and 3 antihypertensive drugs. And we come across that more than 35% of patients who were not at BP goal at baseline achieved their goal in a year with the goals of 39%, 45%, 41%, 45% with 0, 1, 2, and 3 prior antihypertensive. So amlodipine with other antihypertensives is very effective in controlling the blood pressures in those patients whose blood pressure was not achieved. So the last message, amlodipine is a very good drug. Start with the amlodipine if you want to have a single drug combination, or if you want to have a single pill combination therapy, always use the combinations which include amlodipine for multiple reasons which we have discussed, because easy tolerable for the patients, low variability 24 hours of the blood pressure while on initiations, and effective control of blood pressures to minimize the risk of cardiovascular and cerebrovascular events, morbidities, mortalities, and in the end to have a good quality of the life. So control your blood pressure, stay happy and live happy. Thank you.